Welcome to the MS&Me Radio Network. The broadcast shows are for informational and entertainment purposes only. They are not designed to provide listeners with specific personal, medical, or counseling advice. Individuals with a medical issue should always consult their healthcare provider. MS&Me is not responsible for content of individual shows. The views expressed by show hosts or their guests are their own. Enjoy the show. Welcome to MS&Me Interviews. I am your host, Erica Lyons Richardson. Today we are continuing our hashtag We Have MS series for 2018. Our topic today is edition 2 of questions we received from patients who have been recently diagnosed around the globe. The questions have come in through our various social media platforms and forums. What has been most surprising is the lack of basic disease information provided to these patients when diagnosed. That was revealed through their questions, and they had no idea that the most common MS symptoms were in any way disease-related. Also concerning was their confusion on what their response should be when one of these symptoms would arise. When do we call our doctors or MS nurse? How long do we wait? When should we go to the ER? Or navigating basic life with MS and becoming very stressful due to lack of knowledge. That's when the officers of MS&Me Media decided to start compiling the most often observed questions on our social media and bring those to you in a Q&A format several times during 2018. As a disclaimer, most of the questions are being answered by fellow MS patients who have been living with MS for decades and not by medical professionals. It is our hope that the information you hear here will open a dialogue with you and your physician. Let's get started with our Edition 2 questions. Make sure you check out Edition 1. It was actually very informative. Now, the first question is, my first MRI showed 13 brain lesions. Should I be concerned that I have so many? The number of lesions does not necessarily impact disease severity or progression. It's more about the type and the location in the central nervous system. For the brain, specific lesions on the MRI seem to predict how severe the disease will get. They're called T1 hyperintense lesions. They look bright when you look at the image. They're different than lesions known as the T2 hyperintense lesions. For spinal lesions, the level of physical disability is impacted by how high up on the spine and how large of a lesion. Does it, transverse completely across the spinal cord? So patients with, let's say, spinal cord lesions, they're just more likely to develop things like bladder dysfunction, like urinary urgency or hesitancy, partial retention of urine, mild urinary incontinence, bowel dysfunction, constipation, urgency. The constipation's a huge issue sometimes. Sexual dysfunction, erectile dysfunction, or impotence in men. Then genital numbness or complete, the paralysis feeling, pain with intercourse, for either sex. But definitely with women, that numbness can be an issue. A complete loss of bladder and bowel control may be lost in more advanced cases of MS. But spinal cord lesions can also lead to sensory and motor deficits, including dysthesias, spasticity, limb weakness, ataxia, or other gait disturbances. Lesions higher up on your cervical spine, between say C5, C6, can cause weakness or paralysis from the chest down. Lesions like C1 through 4 can cause weakness or paralysis from the neck down, including muscles responsible for breathing. So it can be very serious. So as you can see, the lesions, it'll be more like the size, the intensity, the actual position of the lesions can be more predicted of, disease progression and your actual dysfunction, disability, than the number of lesions. You might see people ask that in MS groups online. And they'll say, how many lesions do you have? And people say, oh my gosh, I have 20, or I have 140. And they think, oh, I'm so sorry, we'll pray for you. And that's usually their response. And it's not necessarily indicative of how disabled that person is by their disease. Another question we see a lot is, are there other treatments besides steroids that can stop the damage during an attack or relapse? Yes. The good news is that not all attacks require treatment. Mild symptoms like numbness, pins and needle sensations, or increased fatigue that don't significantly impact the person's activities can generally be left to improve on their own. But for severe attacks with symptoms like loss of vision, severe weakness, or poor balance that interfere with a person's mobility, safety, overall ability to function, most neurologists recommend a short course of high-dose corticosteroids to reduce that inflammation and bring that relapse or attack to an end more quickly. Now, whether you have diabetes, adverse reactions to the steroids, bone density loss, or just want another option besides steroids, there are other options. HP Acthar Gel is a highly purified preparation of HCTH. That's the adrenocorticotropic hormone in a gel that's designed to provide extended release of the ACTH following injection. It's an FDA-approved treatment for MS relapses in adults. And Acthar Gel works by stimulating the outer layer of the cells of the adrenal gland, promoting the production of the natural hormones that reduce inflammation. So when someone experiences an attack, inflammation typically occurs along the protective covering of the nerves, the myelin sheath that we all hear about, and an increase of lesions usually seen within the brain, spinal cord, etc. So by reducing that inflammation, the disease flare-ups can often be reduced in terms of severity and duration. So that solution, that preparation is injected either into the muscle, called intramuscularly, or under the skin, which is called subcutaneously. And that Acthar Gel injections, they're usually given once daily for 2 or 3 weeks to treat a severe attack, although the dose frequency, is determined patient by patient by the physician. Now, once injected, that gel is absorbed slowly into the bloodstream. So upon reaching the adrenal gland, then of course those natural cortisols are produced. So that's a good option for some patients. Now, plasmapheresis or plasma exchange may be considered for severe exacerbations that do not respond adequately to, standard IV steroids or Acthar Gel. So plasmapheresis is a procedure in which the whole blood is taken from the person and separated into plasma and blood cells. The plasma is removed and replaced with another solution, such as saline solution, albumin, specialty prepared donor, even plasma. And the reconstituted solutions then return to the patient. So plasmapheresis is used in the treatment of many conditions, including autoimmune disease like MS. And when the plasma is removed, it takes it with it the antibodies that have been developing against your own tissue in an attempt to reduce the attack on the patient's, your own body. So that is a good option. So there are other options besides getting, IV steroids or oral steroids when you've had an attack that requires treatment. Now, another question we often see is, I'm having trouble determining if my child's bath water is too hot. Is that normal with MS? Numbness and sensory issues in the hands are a potential issue for patients living with MS. This can become potentially dangerous when it comes to hot water for baths or showers, when you're washing dishes or boiling food. I found that as my ability to detect temperature of water decreased, that I had to move to like a higher spot on my arm to test the water temperature. And eventually I had to have my husband check, even for my own showers. And using a kitchen thermometer can assist you if you live alone. Another dangerous area was the kitchen. There can be potential burns from hot dishwater, boiling water in pots, hot handles on the pots and pans. So having someone else in the family assist or using that kitchen thermometer can help you and prevent severe burns. Okay, another question we received, let's see, was, does MS cause pain? That was a very hot button issue because, as you know, we hear about pain medications being in the news a lot, especially here in the United States. So yes is the answer. Yes, there are several types of pain caused by multiple sclerosis. Now, not all patients will experience each type of pain that can occur with MS. Steady and achy types of pain in MS may be the result of muscles. They become fatigued and stretched when they are used to compensate for other muscles that have become weakened by MS, by that nerve damage. People with MS can also experience that more stabbing type pain, which results from faulty nerve signals. They emanate from those nerves due to MS lesions in the brain, the spinal cord. The most common pain syndromes experienced by patients living with MS include like headaches, which are seen more in MS than the general population, continuous burning in the extremities, back pain, painful tonic spasms like cramping and pulling pain. Experts usually describe pain caused by MS as musculoskeletal, paroxysmal, or chronic neurogenic. So your musculoskeletal pain can be due to muscular weakness, spasticity, or imbalance. It's most often seen in the hips, the legs, and the arms, particularly when muscles and tendons and ligaments remain immobile for some time. Back pain can occur due to improper seating or incorrect posture while walking. That compensation that we do. Of course, it can also be caused by other things like, degenerative disc disease and other things. Now, contractures associated with weakness and spasticity can be painful. Muscular spasms or cramps, called flex or spasms, can be severe and discomforting. It can be really severe. Leg spasms, for example, often occur during sleep. Oh, the night leg pain can be unbearable sometimes, as most of you know. The common treatments include muscle relaxers, Tegretol, or baclofen pumps. There are several treatments for that type of pain. Paroxysmal pain are pains that are seen in between 5 to 10% of patients with MS. The most characteristic is facial pain of trigeminal neuralgia, which usually responds to medications like anticonvulsants such as carbamazepine or something along that line. But as many people with trigeminal neuralgia No, it is one of the most difficult types of pain to treat. People get nerve blocks. They've tried many, many treatments, and sometimes they get very little relief. Um, Trigeminal neuralgia can be on one side, which is most common, or you can have bilateral. It is damage to your fifth cranial nerve. It's often mistaken for sources of other pain. Sometimes people think they have TMJ. Sometimes they think they might have an earache or some other type of pain, and it's actually damage to that fifth cranial nerve. Now, the other type, neurogenic pain, is the most common and distressing of the pain syndromes in multiple sclerosis. This pain is described as constant, boring, burning, or tingling, intense pain. It often occurs in the legs, which we're so familiar with. Paresthesia types include pins and needles, tingling, shivering, burning, feeling of pressure in areas of your skin with heightened sensitivity to the touch. The pains associated with these can be aching, throbbing, stabbing, shooting, gnawing, tingling, tightness, and numbness. Common treatments for these are Neurontin, Lyrica, gabapentin. So the nerve type treatments, often seen, with neuropathy pain from patients who have like diabetes. Now, dysesthesia types include burning, aching, girdling around the body. These are neurologic in origin and are sometimes treated with antidepressant type medications. Drugs that treat seizures like carbamazepine and antidepressants such as amitriptyline are often effective in the cases. Now, things that really frustrate newer MS patients is when they go to the ER or their own doctor refuses to dispense narcotic pain medications for MS pain. Because traditionally you think, okay, I have pain, so give me a narcotic pain medicine, right? That's what we're used to. But that's not the case. What they don't realize is that they are most likely not being treated like drug seekers or lied to if they're told that true MS pain is not treated by narcotics. Patients living with MS can have other conditions that require narcotic pain medications. However, most MS centers and MS specialists, they don't prescribe narcotics to their patients. They're referred out to a pain clinic if they have other conditions that do require narcotic pain medications. But as many of you living in the United States know, that even other medications that we do get treated with for our neurological type pains are now also becoming controlled substances, not as highly controlled, but still controlled substances. Things like our gabapentin, Lyrica can be now in that drug class and controlled because people are abusing them. So it is becoming harder to obtain these type of treatments. But there's so many questions that new patients can have. And it can be quite confusing for them when they don't get answers. When they're first diagnosed and they're expecting, someone to tell them, okay, tell me everything I can expect with my disease. Tell me everything that could happen to me. And so many of the patients are giving just, some very basic information, some pamphlets, possibly some information on a treatment that is prescribed to them or some options for treatment, and they're sent home. And we come on social media forums and we're all discussing, well, I've been diagnosed this long, that long, and we're getting very basic questions from these patients, my fingers are tingling. Anybody else having this happen? When I walk, my legs feel heavy. Is anybody else feeling this? My face is twitching. Does anybody else's face twitch? Just very, very basic questions that if you Google it, as we all love to Google, you will see it listed as, some of the basic top, at least top 50 symptoms from multiple sclerosis. So you wonder why patients don't even know if this is related to their disease. So that's why we've started this series. And we hope throughout the year to bring you more of these that will feature some of these questions, these basic questions that we're seeing that completely surprise patients. That the information is sometimes surprising to them, even though those of us that have been living with MS a little bit longer might think it's just basic information that everyone knows, but they don't get this basic information, and that's why we actually started MS&Me Media. We wanted to find a way to get that information beyond, normal social media or local support groups, because there are places in, our global audience that they don't get this type of information as readily. Not everyone is on social media. That's why we started the radio network. We wanted to reach further and further to share this information with more of our MS community, and to even find ways to reach beyond the MS community so the general public would also have knowledge of multiple sclerosis. Think about it. So many times we will go to an ER with a basic MS symptom like, let's say, an MS hug, and the staff is just completely baffled at first sometimes by our symptoms. I've even been treated for a heart attack when I have presented with MS hug symptoms in the ER. And twice that's happened to me, actually. I've been under a severe attack, went to the ER for actually the severe attack, not the MS hug itself. And while there, having the severe relapse, I also started presenting with a very severe MS hug each time. And the ER staff just went, immediately to MS protocol. Sorry, not MS protocol, the heart attack protocol. And this was actually talked about in an article that I was interviewed for in last month's Momentum magazine from the National MS Society. And this is not an uncommon experience, it seems like. And of course, I let them do the testing. I did stop them with the nitroglycerin. I'm like, oh, let's wait till the testing comes back. Go ahead, test my heart. Let's see what's going on. And I let them shove the baby aspirin in my mouth. But I did want them to double check, but I was quite sure it was an MS hug. My mom actually brought up a video on the MS hug up on YouTube and showed the ER staff. And they were like, oh, okay, that does look like what she's presenting as. And then when the tests come back negative for a heart attack, then, of course, they realized it was the MS hug, gave me the medications, including muscle relaxers, that I needed to get through that until it eased. But it's a common experience. So if you are at an ER and you're like, I have MS and I'm in extreme pain, don't be surprised if you will hear an inexperienced, physician or clinician say, oh, but MS doesn't cause pain. They mean, in their experience and their wheelhouse, they know it's not treated by narcotics. But that doesn't mean it doesn't cause pain. It's just that they're not an MS specialist. They're not trained in multiple sclerosis. Clinicians in an ER setting, they're trained in traumas and things like that, and they have to have a general knowledge across the board, but they don't have the specific knowledge on these neurological diseases many times. But you can learn to be better treated in situations like this by having knowledge of your type of pain so you can describe it to them in more of a specific manner. You can say, oh, I'm having pain from my neuropathy. You know, I have lesions here or there, give the location, and it causes A, B, C, and D, all your symptoms, and tell them I'm having musculoskeletal pain. Then they'll know how to treat it. They'll know how to treat neuropathy, what types of medications. They'll know how to treat your musculoskeletal pain. They'll know how to treat your discomfort from your spasticity. If you know how to describe what you're actually feeling and the source of it, then even someone who's not an MS specialist will be able to help you and ease your discomfort or your extreme pain, whatever the case may be. So many times it's all about educating ourselves so we can be better health advocates and we can be better treated in those situations. So that can be very important. And that's really why we're doing this series, is educating our MS brothers and sisters so they can go out and receive better treatment at their physician's office or in an emergency situation, whatever the case may be. But we definitely continue this series, expand upon the information provided, and don't forget that there are many, many more that we'll discuss on future shows. So check out edition 1 of our new patient Q&A on YouTube. It's already on our YouTube channel, and you can find that at MS&Me Radio. So search for that on YouTube, and that will pull up for you under MS&Me interviews. So there are playlists on our YouTube channel of the different shows. So you want to look under our show, MS&Me interviews, for that actual edition, number 1 of our Q&A. So thank you all for joining me this week. As I said, we will continue this series throughout 2018. So for additional MS information, visit our website at www.msandmemedia.com. That's msandmemedia.com. Join me again next week on MS&Me Interviews.